we start from the schedule. We still, if you look at the preeclampsia, we have definitely more questions than answers. That's why I try to divide my lecture on this separate part, and that's why I tell you something about the screening, also about the prediction of perinatal outcomes, and let's try to show we should distinguish and stratified different approach to two types of the preeclampsia. And finally, maybe we consider the new definition, because still the definition as we know develop and change. And from the first definition in the end of the 20th century, we had at least 4 or 5 times change of the definition of preeclampsia. So let's start. Screening and new model. Probably all of you on this cell know this paper. That's the most famous about the screening for the preeclampsia in the first trimester, according to ultrasound, the uterine arteries, the measure of the blood pressure, and also the angiogenesis markers, especially PLGF in the first trimester. And that's according to, this was concentrated just only on the preeclampsia and implementation of prophylaxis with the aspirin and with the effective, especially for the early onset of the preeclampsia. But we also conduct this kind of the research. So we show, as many other scientists, that we can concentrate also generally on the adverse outcome, perinatal adverse outcome. If we start to predict in the first trimester and we use this screening, we can predict the high-risk group for many others complications in the second part of the pregnancy. If we use the PLGF and cut off on the 1 to 100, there's in our group, there's a more or less 1,000 patients, and the high-risk group discover the over the 40% in this group develop at the end of the pregnancy complication, which was connected with the placental insufficiency many times of the clinical manifestation. Of course, if we don't have access to the PLGF, we can use also PAPA, and it's also effective, and it was also presented in this study. Question is, what cutoff we should use it? It's so presented in the ASPER trial. This means the 1 to 100. Or maybe we should increase the cutoff to 1 to 50. This was much more effective and show us the really high-risk group, which we should concentrate in the course of the pregnancy. This is very interesting issue, but it's not the end of the prediction. We can opportunity stratified in the second trimester. The doctor mentioned about the ultrasound, which is discover the anomalies like ventriculomegaly. But also we have the opportunity to concentrate on the prediction in the second scan. And it's allow, I just only put your attention on the preeclampsia before 32nd week of pregnancy, and if we use the same algorithm plus PLGF and the second marker slit, we can concentrate only on the less than 1% of the population, and we can really discover and predict serious complication at the second part of the pregnancy. How it's working, I'll show you in 2 examples. First case, the patient has the high risk. There's a first pregnancy with the high risk of the preeclampsia. So we implemented, after the first screening, we implemented aspirin. Unfortunately, she came to us in the second trimester, and we discovered there's something going wrong. There's a baby is a little smaller. And look like the uterine arteries flow. That's incredibly high resistance in the both arteries. So according to Nikolai's algorithm and the fetal medicine algorithm, we perform all portions. This means additionally mean anterior pressure and 2 biochemical markers, the PLGF and SLIT. And look at the results of the PLGF, really low, and the second SLIT really high. It's definitely, this balance is disturbed. So look on this underline, red line, the probability development of the early onset preeclampsia, it was 1-to-1. It was 20 weeks of pregnancy, and this is final results of this pregnancy, the 20 weeks of the severe preeclampsia with FGR and delivery, unfortunately. So this allows us to concentrate on the right patient in the course of the patient. I have to mention, because in the ultrasound and the anatomy was totally normal. And the second, totally opposite, first pregnancy ended with FGR and HELP syndrome and the 34 weeks of pregnancy. It was the history of the first pregnancy. Look on the curve, growing curve, and the results in the 34th week, almost only 1,200 grams for the baby. And she came again in the second pregnancy, first trimester scan, 12 weeks, and look, totally normal uterine arteries flow, normal mean arterial pressure, and also acceptable PLGF. And according to screening to FMF, this have the really low risk of the preeclampsia. I remind the first pregnancy and that very severe complication. So according to our present knowledge, we have no indication to the aspirin prophylaxis. And we recommend don't use it. So that's a second scan. That's really normal size of the baby. And again, the same algorithm. This means it show the normal flow in the uterine arteries, normal value of the angiogenesis markers, and what is the final results? Normal delivery and the 39 week of gestation with the normal size of the baby. So it allows us to concentrate on the right patient if we have the high risk and the low risk in the second trimester. This is an option. Next part, my lecture, prediction of the perinatal outcome. So a couple of years ago, our team pay attention of the world, the scientist world, that we have to opportunity use angiogenesis markers as a feature to predict adverse outcome. And we show that using only these features, only angiogenesis markers, we can show that we can predict small babies, we can predict preterm deliveries, and also worse perinatal results. Definitely, it's developed very quickly, and this is very interesting research from Julia Binder and Professor Kali. That was all patients which was included to this research presented chronic hypertension. That means that's only people with chronic hypertension. This is very important. And in the course of this pregnancy, they presented many different clinical presentation. Of course, if developed preeclampsia can occur the proteinuria, can occur the FGR, and now we have additional factor, let's say angiogenesis markers. This is a complicated table. I'm not going to now discuss about it. That's why I cut out some part of this table and present only the situation when we had the patient with the chronic hypertension, I strongly underline, and the two columns. One column, this is a patient with the angiogenesis disturbance, and second with the normal status of angiogenesis markers. And look at the results. Last line, composite adverse perinatal outcome. 75% of this group presented adverse perinatal outcome. Only 10% with the angiogenesis normal markers has the complication. Again, opportunity to write stratification and predict the results. And this is probably the most valuable research presented in this part of the lecture. This is from the United States, 70 centers. Complicated graph, but definitely needed to describe and to talk. So I concentrated on the two curves, one the red and the second violet. Look, we had at the start of this research 139 patients with the preeclampsia in all of the group. And if the patient presented normal status of angiogenesis markers, that's it. After 5 weeks, that's 5 weeks, that's 35 days, this was still 65 patient was the pregnant. And if this look at the last line, the violet curve, let's say only 2 patients was still pregnant. What does it mean? We have the excellent feature, the excellent diagnostic markers, which allow us predict the complication. That's why, after this research, in the United States, it was included to the schedule. And another one aspect of the angiogenesis markers, 2 types of preeclampsia. So we know the placental insufficiency that's mostly concentrated only early onset. And this is exactly very connected and coordinate with the angiogenesis markers. If you look on this presentation, that's maybe I go to the graph because I see the people make the pictures. Yeah. That's we know now we concentrated on the cardiovascular system and so on, but it's not subject of today's lecture. That's why we have put our attention just only on the angiogenesis markers in these 2 types of the preeclampsia. And look at this. If we look at the early onset preeclampsia, almost all patients before 34 weeks of a pregnancy present angiogenesis disturbance. And at the opposite side, only 50, that means only half if we talk about late onset preeclampsia. This means we have totally different pathogenesis in some part of the preeclampsia. That's very important because we should start consider we talk about the same disease. And maybe we only discover the final clinical issues and we talk about the many pathogenesis. It's confirmed in many other clinical presentations. It's presented also, it was eclampsia. Only 1/3, if presented at term, presented the angiogenesis disturbance. The same situation was confirmed in the HELP syndrome. We have the 2 types HELP syndrome with and without the angiogenesis disturbance, and the final result is much worse if the angiogenesis disturbance are present. This is a conclusion. So, another part, redefinition according to biomarkers. It's happened 2 years ago. That's very important for us association, the society, that's the International Society for Study of Hypertension in Pregnancy, again modified the classification of the preeclampsia. And look on this criteria. These angiogenesis markers, first time, were included to the definition. Look also on this, the placental abruption is also included. But in this moment, I would like slightly forget about the angiogenesis markers and pay your attention on the first line. This means the above 20 weeks. I'm working quite long, and so I remember everyone repeat me, the preeclampsia, there's always hypertension and something additional. In my point of view, that's not true, and we make mistake because we concentrate just only on the clinical issues, don't understand the real pathogenesis. That's why we presented last year some of the review atypical preeclampsia before 20 weeks of pregnancy, and look what's happened. This was over the 40 researchers, which included over 34 clinical cases. These are 3 of our center. Before 20 week, patient without hypertension but presented placental insufficiency, many clinical issues. Most common, they say intrauterine fetal death, but all of these patients which has the changes in the uterine arteries, they presented some suspected placental insufficiency, had the disturbance in angiogenesis markers. These disturbances were really huge. Look, the ratio is over 800, over the 300. It was also confirmed in the other researchers presented in this systematic review. There's the conclusions. So this may be time to consider the different approach and think about the placental insufficiency also before 20 weeks of pregnancy, opposite to present definition. And now I presented the final case. I don't know exactly how explain and how to support our management, but it was quite interesting. Look at this. It's just only like a case. The patient came to us to the admission room, and she had the CTG, quite normal, without any disturbance, presented no any other clinical symptoms, no any history, no normal cause of the pregnancy. This was the 10 a.m. Was admitted cause there's a latent phase of the labor, and a couple years, then precisely 10 years later, 10 hours later, she had the tachycardia in the CTG, shallow deceleration, and the small bleeding. The colleagues on the duty decided on the cesarean section was the partial placental abruption, and we sent the request to our laboratory. They had the collected blood sample, and we discover angiogenesis disturbance. That just present as a case. I can't answer how to predict this kind of the clinical situation and how to avoid eventual complication, but it's also interesting issue. So that's a final take-home messages. Disturbance placental, this means angiogenesis markers, suggests placental pathogenesis. Another one, clinical manifestation of preeclampsia seems to be final results endothelial dysfunction, but not necessarily with the angiogenesis disturbance. Angiogenesis markers are good predictors perinatal outcomes. New approach to the pregnancy surveillance allow to better monitor and diagnose high-risk group patient in all trimester. Placental insufficiency can occur before 20 weeks of gestation and can be diagnosed thanks to angiogenesis marker. Thank you for your attention.
Thank you, Professor Sebastian. It was a wonderful talk on angiogenesis markers as a game changer in prediction and diagnosis of placental insufficiency. And I'm sure that a lot of people will take home a lot of messages of the same. And I would like to thank you for participating in this conference.